Good evening and welcome all. On behalf of Maha-IP, I am welcoming everyone. Dr. Chetan Shah sir, who has joined us today, is guest of honor. Our Maha-IP President, Dr. Gangolia sir, is not due to his other commitments. He is not joining today. So at the outset, I'll request Chetan Shah sir to give his blessings for the program. Then we'll start with the things. Over to you, sir. You need to unmute. Yeah.
Good evening, everyone. And at the outset, I like to thank the Maha-IAP office bearers as well as members, and of course the scientific convener, Dr. Mohite sir, and all the esteemed faculties. Now, this series has been picking up and looking at the title Mentor and Mentees. Naturally, we get the best of the things from students, and which are well explained by the experts in the field. And here we have, I think, the three of very, eminent expert, Dr. Tushar, Dr. Sudha Madam, as well as Dr. Shilpa Madam Kinjwadekar. So I think with this esteemed faculties, we'll have a great learning episode, and which will be well moderated by the two learned moderators. So looking at the topic, menarche, which is really a problem whenever a young girl comes with the parents. And parents come to us, they complain us. Really, we are, as a general pediatrician, if you see, we are quite perplexed how to answer them. And naturally, the ongoing discussion, I think upcoming discussion will enlighten us regarding this issue and make us more comfortable and more confident in answering these questions. So I think thank all of you again and wishing you happy learning for next 1.5 to 2 hours. Thank you so much.
Thank you, Shah sir. Actually, we as general pediatricians, when we are practicing, we are used to handle the babies since newborn age. And once they start growing, a girl becomes 15 years, 14 years, 13 years, and then suddenly there are problems which seem to us like they are adult problems. Should we send these girls to the gynecologist for the further problems, or should we handle primarily? All these are confusing things for us, or at times we feel lost. So now we thought Mohite sir also suggested this is very good topic for us with many take home messages and tips, practical tips for us. So today we are having esteemed speakers, Dr. Sudha Rao madam, Dr. Sucheta Kinjavadekar madam, Dr. Tushar Godbole sir, and Dr. Jaya Shivalkar madam, joining from all over Maharashtra. Now I hand over the proceedings to Renu Boralkar madam. She will introduce the speakers and then we'll go ahead. Over to you, ma'am.
Thank you, Dr. Nilima ma'am. Welcome one and all the respected dignitaries on and off the dais, our dear respected pediatricians and my colleagues. Today's is the fourth part of this our mentor mentees program. As sir has rightly said, Chetan Shah sir has joined for first episode also, and now is today present also, and we are so much happy, sir, to have you here. I would like to introduce our renowned teacher, Dr. Sudha Rao ma'am. She is MD and fellow in pediatric endocrinology from UK, presently professor at BJ Wadia Hospital for Children and HOD Department of Pediatric and Chief of Division of Pediatric Endocrinology. She is also attached to Jupiter Hospital, Thane, and presently she was in the member expert Maharashtra COVID-19 Task Force 2020-21. Her area of interest lies in pediatric endocrinology. We know all, but also DSD and neonatal endocrinology. She is the teachers of teachers, and so we in our say that she's the mentor and she's the guidance, and also she will guide us in these proceedings in next 1 hour or so. The next speaker is Dr. Sucheta Kinjwadekar ma'am. She is the leading obstetrician from Navi Mumbai, practicing at Kamlesh Mother and Child Hospital since 1992. And in clinical practice, she has her field of interest managing very high-risk mothers and high-risk babies, obstetrics ultrasound, and she has been trained in fetal ultrasound. In public health, she is a Manyata Assessor Champion. She is also past president Navi Mumbai OBGY Society, and she's also a Lakshya Mentor, Foxy UNICEF Project, trainer, Safe OR course. The next speaker that we have is a young and dynamic, our own Dr. Tushar Godbole. He is from Nashi. He's pediatric and adolescent endocrinologist, director, Harmony Health Hub, Nashi. He's associate professor at Dr. Vasantrao Pawar Medical College, Nashik. He has many book chapters written in Ghai's textbook of pediatrics, IAP textbook of endocrine, and PG textbook of pediatrics. He has 4 national and 5 international publications to his name. He was the EB member of ISPE 2015, 16, and 1920. He was the editor MahaAP Bulletin 2015, 16, and he has won Sarla Vaishnav Award for Best Research Paper in Metabolic Diseases, IAP Delhi 2010. Next is our own Dr. Jaya Shivalkar ma'am. She is the developmental pediatrician and she is also a child as well as adolescent psychologist. She's practicing at Nagpur and she has carried out more than 100 workshops for various field in the field of developmental pediatrics and psychology for parents, teachers, students, and rehabilitation professionals. She is presently a member of State Committee Mental Health. With this short introduction of each of the eminent teacher and mentees, I would now request Dr. Sudharao ma'am to give her expert advice on the session of this Menarche early and late. Over to you, Dr. Sudharao ma'am. Welcome, ma'am. I think ma'am's internet has lost. I have seen her joined.
Yes, she has joined. Sudharao ma'am, kindly unmute.
Ma'am, unmute and start your video, please.
तुषार कॉल करतो का मॅडम नंबर?
Yeah, she's joining.
Can
Yeah.
you hear me?
Yes.
Yes, ma'am. We can hear you, ma'am.
Can you
We
hear
can.
me?
Yeah, we can hear you, ma'am.
Internet issue.
Ma'am, you can keep your video off and you can start your audio only. Maybe the internet issue is there.
Okay. Thank you so much, Dr. Mahesh, for inviting me, Mahesh Mohite, for inviting me here. It's a very important topic, menarche. Menarche is not all that simple subject to be dealing with in relation to the PD perspective.
Pallavi, ma'am, can you help it out here?
Ma'am, actually her audio is not working. And from one ID she has left again.
Okay, she may rejoin again.
Yeah.
Till then time, I think, sir, Mohite sir, do you want to add something on this topic, sir?
Oh, not really. I think we already spent about 10 minutes.
Okay, so yeah. So first in the line, I would request Dr. Tushar Godbole to please start his talk. He would like to have a case-based discussion on endocrine aspects, tips for general pediatricians for early and late menarche. Over to you, Dr. Tushar.
Sure. Thank you so much, MahaIP, Dr. Mahesh sir, Dr. Amol, and all the team members for conceptualizing this. It's a quite important topic, and we are having a gynecologist and also an adolescent expert, in addition to myself, talking on this important topic. I hope my slides are visible in full screen mode.
Yes.
Yep. So in next 12 minutes or so, I'll be touching upon various endocrine aspects of menarche, including the late and the early menarche. So what is menarche? All of us know that it's the first menstruation that a girl ever has in her lifetime. So in endocrinology, we have always followed this sequence of thelarche as the first sign of puberty, followed by puberty, and then the menarche as the culmination or the last event, supposedly the last visible event in the girl's pubertal progression. It generally takes around 2 to 3 years for a normal girl between her thelarche, that's the breast bud appearance, that's the first sign of puberty, and the menarche. So the average age could be anywhere between 2 to 3 years, but generally it takes 2.5 years. So for example, a girl has had her thelarche on the 10th birthday, she will have her first menses at around 12 or 12 and a half. High BMI is sometimes associated with early maturation, and probably that's one of the reasons why we are seeing a little bit secular trend in the age of menarche. So this is the secular trend in menarche over last 50 years, reported across the country. So in 1962 we have the earliest paper from Nagpur, giving the average age of menarche as 14 and a half. In 72, the ICMR paper from Maharashtra, it gave away the age as 13 years and 9 months. In 1981, it was 13 years and 2 months. 1999, this paper from Pune again comes as 12 years and 6 months. 2011, 2016, 2020, 2021, there are 4 papers from 4 areas of Maharashtra that report age group anywhere between 11 and a half to 12 and a half. Last 2 years, I'm sure all of us have had multiple cases coming to us, walking into our clinics and having their menses anywhere on their 10th birthday or even before that. So this is the secular trend, and the reasons that are given generally is the increasing incidence of obesity, and probably this indicates a relationship between the energy balance and the reproduction. So with better nutrition, increased obesity, we have increased leptin as the hormone along with your insulin resistance. There are endocrine disruptors like DDT, lindane, and phenol derivatives, and also some insecticides. Plus there is some media exposure and stress adding to the problem of secular trend in puberty. So this is first case that I'm going to discuss. She is, let us call her Ritu. She is 9 years and 6 months of age. She has entered your OPD crying. And what's the reason of crying is she has had her first menses. So you can relate to this because on a daily basis, we are seeing such cases. 9.5 years, quarter to 10 years, 10 years, these girls are walking into our clinics with menses. So my first question to this girl or her parents was, look, she has had her first periods, and obviously she's crying. That means she is not psychologically ready. So did it come as a surprise? Did you not pick up the signs of puberty? So the parents say that yes, we had we noticed that the girl had breast development on her 8th birthday or just before that, and we had visited one of our gynecologists, but the OBGYN said, oh, it's common nowadays, sabko ho raha hai, usme kuch nahi karna hai, and that's why we did not do anything. And now the girl has entered her menses, and the parents probably did not understand the rapidity with which the girl was developing into puberty, and as a result she has now had her menses, and she is devastated and she is not psychologically prepared. So what went wrong here? She's of course tallest in the class as of now. She is 150 centimeters, and her bone age at 9 years and 6 months is 12 years. So what all clinical clues did we have here? She is obese. She is tall in her class. She had her breast development on or before 8th birthday. She also has acanthosis nigricans over her nape of the neck. And these are the girls that are, commonly seen entering puberty early. So obesity, acanthosis nigricans. There may be a history of SGA, that's small for gestational age at birth. So SGA girls are rapidly known to develop into puberty. And plus SGA, small for gestational girls, they generally have the duration between the thelarchy and the menarche that is very brief. So they'll not take 2 years or 3 years. They might just rapidly enter puberty, and within 1 to 1.5 years from thelarchy, they will end up in menarche. So can something be done in this case, and whether we need to treat this case? So now this may be a point to argue, because she has already entered menarche and her uterus is fully developed. Now if at all we decide to treat this girl, then we'll have to give some medicines to suppress her puberty hormones, and it will take some 2 to 3 months for us to bring her estrogen levels back to normal. And within next 2 months she is going to bleed, and she is going to bleed irregularly. So here one may argue that what are we going to achieve by treating this girl, because she is anyway 9.5 years, and she is going to have 2 or 3 more cycles before we can actually successfully treat. So it would have been a better idea to pick her up right on her 8th birthday and discuss this issue, that look, your girl is entering puberty early. There is something called as precocious puberty, there is something called as early puberty. We need to sit with the parents, educate them about the obesity part, educate them about the sequence of puberty, and look, if the puberty is rapidly going ahead, and if the family and the girl is not psychologically ready, then even before the menses have happened, we have an option of treating this girl with something called as GnRH analogs. So while going through the clinical aspect, one has to ask for the onset of breast development, look at the rapidity of pubertal progression, how rapidly it is progressing, look at the comorbidities, whether she was born SGA, is there any history of obesity, is there a family history of early puberty. Sometimes the mom also has early puberty, the atya or maushi, the maternal or paternal aunts may have the same history. Clinical clues such as any squint, any headaches, any acanthosis nigricans, squint or headache for central causes of precocious puberty like tumors, cafe au lait spots for peripheral precocious puberty like in McCune-Albright syndrome, and acanthosis as a part of insulin resistance are the important clinical clues that a pediatrician should not miss in a case of precocious puberty. So whenever dealing with a precocious puberty girl, we have to see whether this is sustained or ill sustained. So in our case, it was well sustained because she came to us with thelarchy, then pubarchy, then menarche, and it was a rapidly progressing. So what hormones do we do? Generally, we document LH, FSH, and thyroid as a baseline hormone panel. When to advise for USG pelvis? When we are suspecting any case of ovarian cyst, or we have any prolonged bleedings, that is the time we can order for ultrasound. Otherwise, routinely we need not. In this particular case that has come to us with menarche, we ultrasound might not really help, except for where you have a discrepancy. The thelarchy is not much, the breast development is not much, the girl is short, and she has had a query episode of menarche. An ultrasound may give you an idea that whether the uterus is mature or not. We have had instances where urinary tract infections or local trauma to the urethra or the vulva has mimicked as menses, and an ultrasound has helped her to counsel the patients that look, this is not real menses because the uterus is just 3 centimeters or 3.5 centimeters, and for a girl to have real menses, the uterus has to be at least 5.5 or 6 centimeters in the longitudinal segment. So if you're not sure whether this bleed is actually menses or not, then an ultrasound can actually help you. When to do an MRI? Not in every case, but if you have central precocious puberty happening before the thelarchy happening before 6 years, or the menarche happening before 8 or 8.5 years, and when you have a central cause, then probably you would do an MRI to rule out the underlying SOL. When to treat? Now, while treating, we have to understand three things the pediatrician should take into consideration. Am I dealing with a pathological variant of precocious puberty? So is there an underlying cause? Underlying cause like an ovarian cyst, such as in Macular Albright, or a craniopharyngioma or any hematoma sitting in the brain? Is there an underlying cause? Second is the final height going to get compromised because the girl has attained menarche early? Is the final height likely to get compromised? And here you need to take help of your pediatric endocrine colleague. And then, is the family psychologically prepared? So my take home message here of the first part, that's the early puberty, is you are supposed to know what is the underlying cause. The central precocious puberty is treated with something called as GnRH analog, where you suppress the GnRH pulsatility, thereby the LH and FSH also go down. It's a safe treatment. And in peripheral precocious puberty, you find out the cause, such as the CAH in males, or in females you have ovarian cysts, and you could give drugs like estrogen receptor blockers or aromatase inhibitors. So secular trend is common. Thelarchy before 8 years and menarche before 10th birthday needs attention. Blanket statement like sabko ho raha hai, kuch mat karo is not correct. That's the message that I want to give to everyone, including the pediatricians and the gynecologists, that you have to individualize the care for that particular patient. Yes, we are seeing a secular trend, but doesn't mean that we need not do anything about it. And treatment with progesterone or tranexamic acid can be done for immediate cessation of the bleeding, and GnRH analogs are effective treatment for central precocious puberty. Coming to second part of my talk, and that is 15-year-old female came to you in the OPD with primary amenorrhea. We have had plenty of discussions on Turner syndrome, so I'm not going to talk on Turner syndrome. We already know that Turner's is a common cause, but here we have another case that comes to us with little or no breast development, primary amenorrhea on 15th birthday, and she also has anosmia. So on history, she says, "Mujhe smell nahi aata hai. I cannot have any smell of agarbatti or any talcum powder or perfumes. I cannot smell anything." So that's a very important clinical clue, that's anosmia, and her elder brother also has developmental delay. So delayed puberty is defined as no secondary sexual characters until 13th birthday in females. The common causes are nutrition. Still in India, we are dealing with malnutrition and anemia being the commonest causes of delayed puberty and thereby primary amenorrhea or late menses. They'll not come to us with isko thelar ki nahi hai, pubar ki nahi hai. They'll just complain that isko abhi tak menses nahi aata hai. That will be their primary presenting complaint. Problems with hypothalamus and pituitary, they are, although not rare. We see cases of hypogonadotropic hypogonadism commonly in our practice. And there is another set of problem, that is problems in the gonads, like in Turner syndrome or in primary ovarian failure, where everything is normal but the ovaries have failed. So we can categorize them in two problems, in the systemic disorders, problem in the hypothalamus, or problems in the gonads. So this is a flowchart that all of us should go through. So the most important clinical clue whenever we are dealing with delayed menses is to look whether there are secondary sexual characters present or absent. If the girl has primary amenorrhea with absent secondary sexual characters, then the problem is either in the pituitary or in the ovaries. So I'll take you to the left arm of this. Secondary sexual characters absent. Then you measure the FSH and LH. If the FSH LH are low, you're dealing with a brain problem or the pituitary problem. If the FSH is above a certain cutoff of around 20 and LH is above 40, then it probably tells you that this is hypergonadotropic hypogonadism. That's the gonadal failure, and the most common cause in our practice is Turner syndrome. So please remember, no secondary sexual characters, look at the LHFSH, that gives you the clue. Now, if you have secondary sexual characters present, then look at the ultrasound. Here is the role of ultrasound. If the uterus is absent, then you may be dealing with something called as either Mullerian agenesis syndrome, like Rokitansky cluster Meyer-Heuser RKMH syndrome, or you might be actually dealing with a male. So if it's a male, with androgen insensitivity syndrome. So an ultrasound, if the uterus is small sized, probably RKMS. If the uterus is absent, then you may be dealing with androgen insensitivity syndrome. And if the uterus is present, then you have to rule out something called as imperforate hymen. And here comes the role of our gynecology colleagues. They can, they are trained in examining these girls for hematocolpos and local uterine problems. And here, when we have secondary sexual characters present, we must take help of our gynecology colleagues in ruling out the causes of secondary amenorrhea, such as local Asherman syndrome or tuberculosis or imperforate hymen. Please remember that PCOD nowadays comes to us with primary amenorrhea as well. So a girl may actually come to you with all signs of virilization and proper breast development with primary amenorrhea. One must think of PCOD as one of the DDs. So to summarize, so before my summary, this hypogonadism in girls has to be treated very, very slowly. All of us, please remember, a girl with delayed puberty, you cannot just write an OC pill, because the girl has to undergo physiological maturation. Her bones, her cardiac health also has to grow gradually. So you cannot just write a prescription of combined OC pill for a girl with delayed puberty. You are supposed to sequentially build her estrogen over 2 to 2.5 years, and then add progesterone. And please take help of your gynecology colleague or endocrine colleague for this puberty induction. So in summary, delayed menarche, suspect hypogonadism if there is no breast development by 13th birthday, or no menses until 15th birthday, or no menses if the gap between thelarche and menarche is more than 3 years, then suspect hypogonadism. Systemic causes are the most common, including anemia and chronic disorders. Presence of secondary sexual characters, suspect uterine causes. Absence of secondary sexual characters, suspect either problem in the hypothalamus or in the ovaries. Short stature is the clue towards hypothyroidism, hypopituitarism, or Turner syndrome. Tall stature is the clue towards hypogonadotropic hypogonadism. And gradual pubertal induction is necessary in girls with delayed menarche with hypogonadism. So with this, I come to my conclusion slide, and over to you, Dr. Renu.
Yeah, excellent presentation, doctor. With your both your cases, you have highlighted all things of the pubertal aspect of early and delay. And I see now Sudha Rao, ma'am. Ma'am, welcome. Please unmute yourself. Yeah, ma'am, you have heard most of the lecture, I think. So,
Yes,
So can you please opine your expert opinion on this parts, ma'am?
As usual. Thank you. Thank you very much. As usual, Tushar has been excellent. And to simplify a complex topic like puberty is very difficult, please understand. Now, the take-home messages which he has spoken of in terms of precocious puberty, which I think I would like to further highlight upon, is the fact that though there is a secular trend which we all speak of, and in this post-COVID scenario, there has been sudden increase in weight of many of our children, and I'm sure all of us must be seeing more girls presenting with thelarche with this change in BMI which has happened because of COVID. So the point that the puberty is to be picked up and differentiated from a sinister cause like true central precocious puberty is very important. And we need an evaluation not only in terms of looking at high potential, as also in terms of accepting the changes which is happening for psychosocial. I'm sure we are going to listen to that in the speaker's time. That is about early puberty, and I would like to tell all my colleagues from the pediatric group and even my pediatric endocrine colleagues that we are doing a study to figure out where
I think ma'am was mentioning about some study.
She's there. She's there.
Yeah. Okay. Yeah.
Unmute yourself.
Sorry. Kisspeptin level seems to be a biomarker which would help us as a single blood test to differentiate between an early puberty from a true central precocious puberty. I think we are going on some way in that way. So one test would be enough to differentiate. Delayed puberty, the commonest cause is still happens to be nutritional in our Indian scenario. And we should not miss out on Turner syndrome in girls who are coming to us with delayed puberty. And an underlying very high-end kind of diagnosis, which is very, very rare, is an underlying DSD, disorder of sexual differentiation, which can present as delayed puberty alone, delayed onset of puberty alone. Excellent talk, Tushar. Thank you.
Sudhara, madam, just one thing you said about one single biomarker for central this
yes.
because of the internet. What is the biomarker?
That's called kisspeptin levels. So kisspeptin is a neuropeptide, is a kind of a stimulant, is an excitatory stimulant for the GnRH axis. That seems to be a promising molecule which would help differentiate between an early maturer versus a true central precocious. Often we do the GnRH analog stimulation test. We need the ultrasound of the pelvis to know the uterine dimensions. So right now there is an armamentarium of tests to help us differentiate an early maturer from a true central. But I think over a period of time, one single biomarker can help. Kisspeptin is elevated in central precocious puberty as compared to early maturers where it would not be elevated. So it's not easily available, but that's being worked upon as a promising molecule.
Thank you. Thank you, ma'am.
Thank you, ma'am, for your expert comments. Now, our next in line is the gorgeous lady, Dr. Suchita Kinchwadekar, ma'am, and she will be having a presentation which is related to the gynecological point of pubertal aspects. Over to you, ma'am.
Yeah, thank you. Thank you so much. I'm really happy to participate in today's discussion, and more so, I think I'll be happy learning more and more things. Tushar's talk was, as usual, very excellent, and he really makes things at least look very simple. Though diagnosis of precocious puberty is not at all very easy to make because of obesity. Girl who is slightly obese on chubbier side, Thilarke, it's really difficult to differentiate, and what madam told just now is a really valid and important point. Well, I think I need to restrict myself to menarche, menstrual disorders, menstrual hygiene, and dysmenorrhea. Importance for this topic to pediatricians, because you people are first point of contact and you should not miss opportunity to educate girls and parents about menarche. You have already good rapport with the young girl and her caregivers, that is her mother and parents. And at each visit, menstrual history should be asked. It should be like a sixth vital sign. So identification of abnormal menstrual patterns in adolescents may improve early identification of potential health concerns during adulthood. Now, while talking about menstrual hygiene, I need to tell few things like about the usage of a pad. Whenever a girl comes to me for the first time at menarche, maybe 10 years, 12 years, even though she knows many things, she is a bit confused. And so I straight away put these things forth, because at times mother has not given any, psychological preparation to her daughter. So pads, that external pads, that sanitary napkins that are used commonly, commercial ones, they are disposable ones. Nevertheless, at many places, cotton pads are still used. And it's a wonderful way of, it need not be a commercial disposable pad, but cotton pad is equally good. Only we need to tell girl that it needs to be washed with cold water immediately and needs to be sun dried. This is very, very important, because reusing damp cloth is not really a good point for her perineal hygiene as far as it is concerned. Now, between these two, commercially used disposable napkin and homemade cotton pads, both are good. At menarche or very young girls, usually they don't use tampons or cups, but nevertheless, I think everyone needs to be aware of it. Tampon is a kind of protection which is inserted in vagina. It can stay there for 8 hours or so, and it absorbs menstrual discharge, and it needs to be pulled out. Okay. Now this can be used especially in girls who are doing swimming and all during their menstrual period. It can still be used even by younger girls. But forgotten tampon can cause toxic shock syndrome, which is very bad thing to happen. And hence tampon is not really encouraged in young girls because they tend to forget things, especially at the end of a period. Menstrual cup, which you are seeing in the picture, is a current in thing, and it's really eco-friendly, and more young girls are using menstrual cups for their menstrual protection. These are medical grade silicone cups. It comes in 3 different sizes, and the smallest cup can be used even by teenager girls. It is reusable. It is to be changed, say, every 8 to 12 hours. And girls, they need some time to learn and understand this. Now, as we are talking of menarche, I am not going further into this, but we need to be aware of it. Next thing is that what we need to tell girls is importance of hand washing. They need to wash hands after changing pad, that everyone knows. But what we need to emphasize that even before changing sanitary napkin, one should wash hands or clean their hands and change the napkin, and afterwards again wash the hands. This is very, very important. How to dispose disposable sanitary napkin? Many girls and even mothers are clueless. Many of them, they just flush it in the commode because they're not aware what to do. So we need to tell them how to dispose. They can dispose it in any newspaper, which is a biodegradable, and then it can be disposed. In various housing societies, in metro cities and bigger cities, nowadays there is a different red bin to dispose sanitary napkins. Nevertheless, if it's not available, it needs to be disposed in wet waste in housing societies, or while you are disposing it. It should not be thrown, it should not be flushed away. These are 2 important points we need to tell our girls. We need to know what is normal, because many times girls come and tell us my period is not normal. So we should be aware what is normal. Now, cycle duration, it can be 3 weeks to 6 weeks, it is still normal. Every girl need not get her period every 28 days or every month or the same day of every month. So 3 to 6 weeks, that is 21 to 45 days of a cycle, is absolutely normal cycle duration. And she needs to count day 1 of a cycle to day 1 of a next cycle, and that becomes her period. You know, because again, many of them are not aware, and what they count is the last day of one cycle and first day of a next cycle, and then tell us that my cycles are very short. Normal flow duration is 2 to 7 days. Anything between this is normal. Premenstrual spotting is normal. End of menses, again, spotting is very much normal. So roughly 3 to 4 days of normal flow of menses is very much normal. Now, pain associated with normal period, it can be ovulation pain, sometimes it is spasmodic dysmenorrhea, and sometimes it is congestive dysmenorrhea. You all know what it is. Now, good thing is, usually at around menarche, they don't feel any pain, because first few cycles are anovulatory cycles, and hence there is no pain. Spasmodic dysmenorrhea also is experienced when cycles are ovulatory, and anovulatory cycles, again, dysmenorrhea is very much less. So pain as such to begin with during the period of menarche is not much. Now, while talking about disorders at menarche, late and precocious, Tushar has covered it extensively very well. I need not go at all into it. Cycle rhythm, disorders of rhythm. So cycles will be too late or they are too frequent. Disorders of flow, oligo, I mean the flow is too less or flow is too heavy, and symptoms. So let's just go through it. Now, my part, that is gynecological part, it comes in the part of amenorrhea, that is cryptomenorrhea. That means she is menstruating regularly, but the flow is not evident. It's the hidden menses. Now, commonest cause is imperforate hymen. It is pretty common, and a local examination tells us that this is imperforate hymen, and a simple surgery is the answer to hematocolpus. Many a times these girls, they don't come as primary amenorrhea, but they come as cyclical pain, because vagina can accommodate tremendous amount of blood in it, and hence she may be menstruating for months together before actually she comes to us. And when probed, then in retrospect they say ki ho madun madun dar mahinala तिचं पोट दुखत होतं. Secondly, this hematocolpus at times results in sudden urethral obstruction, and they come or present as acute retention. So acute retention without any cause, one should suspect of this cause, and you need to probe and ask, is she menstruating? If not, then at least the local examination while catheterization is a must, and that gives us a clue. Now, she is having secondary sexual characters, and there is uterine agenesis. I mean, the target organ is at fault. So that is one more thing where again gynecologist comes into picture. But then at that particular age, what we need to assure parents that her secondary sexual characters are developed. She doesn't have a uterus, so probably reproductive function is going to be compromised. Nevertheless, sexual function, it can still go ahead. I mean, this is not the age that we need to tell this to the child or the young girl, but what we need to reassure the parents about uterine agenesis and what does it means. Many times they translate this कि शादी के बाद सब ठीक हो जाएगा, and that is not the case. I mean, one never ever should say that afterwards things are going to fall in place if there is uterine agenesis. Now, secondary amenorrhea means once or twice she had a period, but later on she doesn't get a period. Now, after menarche, till the age of say 18, 19 or maybe 20 years, this is quite a common phenomenon that she gets her cycles very late, or sometimes 2 months, 3 months amenorrhea, and then they come to us. Here, taking this opportunity, we need to educate the girl about, overall reproduction, the good touch, bad touch, and things like that. Because though nobody says it overtly, secondary amenorrhea, parents are anxious about, pregnancy and the girls having some other relations and things like that. Now, once this thing is ruled out, maybe by an ultrasound or, overall, then we can reassure them that at this age, the HPO axis is a bit immature, and to begin with, ovulation is going to happen very late. PCOS, yes, obvious cause. Eating disorders, poor anorexia, poor nutrition, anorexia, fat diets, stress, exam stress, all these are very, very common causes of secondary amenorrhea, even in young girls. And of course, hormonal causes of primary amenorrhea, like hyperprolactinemia, still exists in case of young girls, and they are also true for secondary amenorrhea. Why endometrium bleeds? We know that endometrium develops through proliferative phase to secretory phase, and one fine day when there is no support of estrogen and progesterone, endometrium just gives way, starts bleeding, and it gets shed off. So amount of bleeding is kind of proportionate to the hormonal activity, that is estrogen and progesterone activity in the endometrium. Plus, there are certain clotting mechanisms which come into picture to arrest that bleeding. And so any of disorder of bleeding is going to cause excessive bleeding. So if girl complains that she gets too frequent cycles, every 2 weeks she gets cycles, then you need to sit and ask which is first day of last period, त्याच्या आधीचा पिरियड कधी आला होता, कधीपर्यंत थांबला, and all that. And then you come to know whether she is really getting cycles every 15 days or they are actually 21 days. Because girls, they tend to say her last spotting or 3-4 days ka spotting also, they count it as a period bleeding and eventually say that cycles are too frequent. Need to rule out local pathology. Here is the role of a screening ultrasound. And in case they are really too frequent, that is every 15 days, because of irregular ripening and shedding of endometrium, if she is getting too sooner a period, then maybe second part of a cycle, a progesterone supplement can be given. Now, it's better to avoid norethistérone derivatives like Carina and Proluton and all things like that, and better to give medroxyprogesterone acetate, which is very less androgenic, because these 19 nortestosterone derivatives do have an androgenic side effect, especially on the developing girls. Now, menorrhagia, that means heavy bleeding. We need to differentiate if it's irregular and if it's cyclical. Every cycle she is getting heavy bleeding, then think of platelet dysfunction, bleeding disorders, or hyperestrogenic states like obesity. And irregular menorrhagia, think of genital trauma, because this is the age girls keep on experimenting. They are becoming slightly, sexually oriented, and this is the time these things may happen, like like masturbation and genital trauma secondary to that. Irregular ripening of a follicle, again the endocrine cause or the ovarian cause, anovulation and PCOS. Typically, there is a period of amenorrhea followed by heavy bleeding. So if it's the menorrhagia followed by amenorrhea, think of PCOS and anovulation, especially in that particular age group. PCOS, I don't think we need to go in detail. Tushar has given this overview as well. Many times mothers complain, doctor, her period is never on time. So what is actually the concern? Because if there is a period of amenorrhea, following that, if she is going to get normal flow, it's not excessive, I don't think we really need to worry. Because her HPO axis is getting mature, it need not be very cyclical and regular to begin with. So her basic concerns are, it's really inconvenience, especially school time. Okay, when to be prepared for your period. Suddenly it may stop in any of the school day, and we need to educate the girl about this. Then second concerns of mother is, will she be habituated and always be getting late cycles? So we need to reassure that again, this is the beginning, and mostly as she grows, she will get her normal rhythm. And PCOS, everybody has heard, they come to you with a diagnosis ki doctor आत्तापासून माझ्या मुलीला PCOD झालाय का. So usually these are the concerns, and we need to give them reassurance most of the time. Many times 3-4 cycles of OC pills are given to these girls, and it really doesn't help them. So it's better to avoid estrogen progesterone combined OC pills in very young age. So we need to convey them, this is a normal variation in cycle duration, it's immaturity of HPO axis, educate the girl to maintain her menstrual calendar, orient her about reproduction and pregnancy and things like that. If previously she was very normal cycles and now getting late, maybe investigations come into picture. Think of, vaccination, I need not tell you, because this is your domain. And treatment, in case it's a amenorrhea, then periodic withdrawal of progesterone. This especially holds true for a PCOD girls or the obese girl. So periodic withdrawal of progesterone hormone for 2 to 3 days and induction of menses periodically, it's very, very important. Sometimes you can give them that liberty to adjust it a little over their exam timings or so, but roughly 45 days. So 15 days overdue of expected period day, take 2-3 days of pills and you're going to get your period. I think that's the way out, plus motivation for her weight reduction and exercise. Now, dysmenorrhea, if pain is a concern, what we need to assure them? We need to tell them that yes, ovulatory cycles are painful. So if every cycle you are getting pain, probably ovulation is getting established, and that's a good thing. We again need to tell her to maintain, menstrual calendar, which is very, very important habit to inculcate in young girls. No need of investigation for dysmenorrhea. What treatment? Proper hydration, high fiber to alleviate Constipation, because premenstrually typically they tend to constipate, less amount of fluid intake, and so we need to educate them about this good bowel movement, and that is one more cause of pain around menses. Then various stretching exercises, pelvic exercises, pelvic rocking, all these things will definitely help her. Playful activities, they release internal endorphins and they are actually natural painkillers. And this is a very good technique to teach them, and various distraction techniques. If mother is continuously saying about dysmenorrhea, daughter is going to pick up the same thing. So, we really need to spend some time and educate them about dysmenorrhea. Nevertheless, there is no harm in taking mefenamic, dicyclomine combination, Meftal-Spas or Colimex or simple paracetamol, and taking NSAIDs once or twice in a month is not going to make much difference. But if pain is so severe that she is missing her school, I mean, she cannot concentrate in her studies, then might as well offer her NSAIDs. Heavy periods, I have told you earlier that you need to actually sit and say that, tell me how much do you bleed on day one? When do you frequently change pads? Because earlier, I mean, at younger age, even with a small dot on the pad, they keep on changing the pad or throwing the pad. So just I need to take 2-3 pads in a day doesn't mean that she's having heavy bleeding. So what does heavy bleeding constitute? That means she needs to change more pads more frequently in daytime, or she needs to change her pad even during night times. If she passes clots, because normally natural menstrual blood is without blood clots. So if she is passing clots, if there is obvious drop of hemoglobin, I mean, now you are seeing that she is turning anemic. So, and if duration of cycle is exceeding 7 days, so any of these, then yes, maybe she is bleeding. Again, OTC preparation, mefenamic acid, tranexamic acid, it helps reducing blood flow like anything. If it's this is the point when you should actually emphasize that each girl should be getting iron supplementation and prevent anemia. If she is not already anemic, every cycle, number of days she is bleeding, at least those days, let her take oral iron as iron supplement. So this is one more opportunity for us to prevent anemia in young girls. If she's not responding to these kind of baseline treatment, then maybe sometimes hormonal treatment is needed. But one has to be very compliant, because what we observe in OPD is they take hormonal tablets. Once bleeding is arrested, they just stop the tablet, or the girl eventually misses the tablet and then she again gets breakthrough bleeding. So once hormone is started, you need to be very much compliant to that. She wants to adjust her period. Sometimes mother, advocates कि exam hai, trekking jana hai, and all these activities, and she doesn't want to have her period at that time. I think this is the time we need to again educate them and tell them that you need not experiment with your body and don't be in the habit of changing or adjusting your periods, because it does have its own side effects. I think that is gynecologist perspective, what we always end up in saying young girls. Thank you so much.
Yeah, thank you so much, Dr. Suchita ma'am. You have covered all the aspects which are related to amenorrhea, menorrhagia, along with dysmenorrhea, hygiene, and also the proper counseling that you say that is required during such teenage girls. So, Dr. Sudharao ma'am, over to you, ma'am, for your expert comments on ma'am's topic.
Again, a very beautifully covered session here. Thank you, Dr. Suchita. There were some. If there are any questions from the audience, we are going to take it at the end, is it?
Yes, ma'am.
Okay. So when we speak of one basic question, which if I can ask Dr. Suchita, if a child comes with menstrual irregularity, should she go to an endocrinologist or to a gynecologist?
That means, madam, you want to ask me if patient comes to you, you want to refer to gynec or to endocrinologist. If she has menses in time, I mean, it's not precautious, it's not late, then I don't think you need to refer also. What you need to do is just, reassure her about the irregularity in initial few cycles. Now it's time to refer if she is getting excessive bleeding following a period of amenorrhea, then probably she may need some treatment. Basic endocrine investigations are just thyroid and prolactin, nothing else. There is no need to do AMH and other tests just to diagnose or label her as PCOD. There is no need to do ultrasound to label her as PCOD. If clinically you feel she is getting irregular cycle, she is obese, there is a neck pigmentation and things like that, it's okay. She can take periodic withdrawal bleeding. That's more than enough.
Yeah, so that is a point which I was trying to make, because many of the girls, the gynecological issue of a menstrual irregularity in our adolescent population, though it is emerging, it is rare. So whenever we have an adolescent who's just entered menarcheal, post-menarcheal age, and if suppose she has an irregular kind of cycle, often it is physiological and the immaturity of the axis, and does not need to does not need to go on any kind of therapy, needs just reassurance and maybe follow her up over a period of time. That is one message. Often it is the mothers who are very anxious that the girl
Very true. Because recently I remember I told the mother and daughter duo came and they said that she's not getting a period. I said, then what? तुला काय problem है? Then that girl said, मला काहीच problem नाही, आईला problem है, मला period येत नाही म्हणून. So it's very true. I mean, at early age, they are more than happy if they don't get period every month.
And does it, having it regularly on the dot, on the date, like you said, is more for a convenience and planning of your schedule rather than calling it something abnormal. Maybe that should be told to them in the first 2 years post-menarcheal age. That is one important thing. And replacement of good amount of nutrition, especially the type 2 malnutrition with the trace elements like phosphorus and others, also helps, iron for that matter, also helps in maintaining your cyclicity quite easily. And very few percentage of the times we are truly requiring a hormone kind of therapy for them. So maybe a referral for a child who's 17 years and plus and who's post-menarcheal for 3 years of age would be a better scenario rather than referring a 10-year-old or 11-year-old who's just started her periods for any hormonal intervention or evaluation. That's physiology. Maybe that's the main. And your talk about the hygiene, people do ask, I'm sure there must be questions coming as to what type of pads to use, which pad is safe. Are there any special medicated pads which we should be advising? Do you have any answers for that?
Whichever pads they want to use, I mean, all market pads like Whisper and similar pads are okay. Even if homemade sanitary napkins made out of cotton cloth, absorbent cloth are equally good, and we need not discourage them if they are using, because I think they are more eco-friendly. What is important is we need to tell them is they need to change the pad even if it is not soaked after 6 to 8 hours. It's the menstrual blood which comes in contact with air, gets converted into the product which is highly, stinking, and that actually gives that skin irritation and rash around. So changing pad frequently is very, very important. 4 to 6 hours is what we always recommend. Nevertheless, when they go to school, they can change the pad at least once in the break time and maybe after coming home. So changing pad 6 to 8 hours or 4 to 6 hours depending on the flow is what is important. That is what is important to tell them. They can use any pad getting converted into gel or all that stuff doesn't matter. There is no need of any antiseptic solution or anything. There is no need of any V-wash kind of things or any alkaline soaps, because they need to wash perineal area with simple plain lukewarm water, then wiping from front to back and not from back to front, especially after passing motion. That's what we need to tell them. And but that is to prevent vaginal infection. And after, there is no role of any V-wash or any vaginal douche, because normal bacterial flora, it's acidic and it needs to be there. Especially after menses, the pH of vagina changes from acidic to alkaline, and they're more prone for infection. So at that time, they need not take extra precaution to wash vagina or vulva. That's all. I think if asked, or even if not asked, we need to tell them, because many mothers are not aware of many facts.
Yes.
So at that is the time when even they become aware, when you are teaching their daughter.
And maybe one important message would be teaching them to maintain a menstrual diary, which I guess is sometimes it is a perceived complaint rather than a true one. So that would be one important message which I think needs to go forward. Thank you. Any other comments, Tushar?
No, it was wonderfully covered.
Yeah, thank you so much, Sudha Rao ma'am. And
if I'm allowed, I just wanted to ask one question or comment. I don't know if at all. Dr. Tushar said, and since endocrinologists are our mentors, cyclical, I mean the long-acting GnRH analog to suppress precocious puberty. I mean, if it is diagnosed beforehand, well and good. If not, after she gets a period, don't you think it's a quite costly proposition? Because getting that injection, long-acting depot preparation, it's costly, it's not easy, it's painful. Then might as well you can suppress her. The another option is injectable Depo-Provera, which suppress menses like anything. She gets hypomenorrhea and then amenorrhea. And after 2 to 3 years of Depo-Provera injection, once she crosses 11 or 12 years, I mean, she can again stop them and start having her regular cycles. Because GnRH, we use this in infertility patients, but for precocious puberty, especially after established menses, and her bone height, bone age has already crossed, then is it worth using it or no?
So Tushar, you want to answer or?
Yeah, I agree. When we need to, just delay it for a matter of maybe 6 months or something, where we are not worried about the skeletal outcomes, and we are okay with the other secondary characters such as breast development, etc. Then I agree that injectable or even oral progesterone is fine. But then when we are worried about when we need to delay it beyond 1 year or 2 year, then, and also when we are worried about the skeletal outcomes, then GnRH analogs are better, because they will stop that fast skeletal maturation. Regarding cost, yes, they are costly, and we have to counsel them regarding the overall cost and what are we going to achieve by giving GnRH analog. The parents have to understand before we make that decision. Ma'am, you want to add to that?
Yeah. So the indication for GnRH analog is not for stopping the PV bleeding. That much all of us must be able to for stopping the PV bleeding. But we are trying to give, usually it is not used there puberty or early puberty. So bone age, if it's reached more than 14, there is no point in giving any GnRH analog. So if the bone age is say less, and you do have some like 10 years, not too advanced, and there is a good enough amount of growth potential, you can improve the final height prediction. There may be, even if it is post-menarcheal, you may use GnRH analog. Now for if there is a psychological, which I think we are going to listen to the next speaker, if there is a psychological effect of the PV bleeding, not only in terms of school performance, there are girls who cry, who don't like those periods, and the school performance does drop with the onset of menses, and which they are only having in the class, and only few of them are having in the class and not all their peers. Those are some psychological stressors which those girls face. And I know there is no which is not so centrally acting, but still can also more counseling and more psychological support would help in the girl looking after herself rather than giving her like NPA. Central treatment, the idea would be general channel, and that would be the therapy of choice, I suppose.
Hello. Yeah, ma'am.
Last part I didn't hear.
Yeah, there was some disturbance in the connection.
Fine.
I think we will move over to our next speaker, third speaker, Dr. Jayashree Shivalkar, ma'am. She will be speaking on the psychological aspects around menarche, including girls with special needs. Over to you, Dr. Jaya, ma'am. Can you start your presentation?
I am getting that host as disabled participant screen sharing.
No, ma'am. Try again, ma'am. Try again. You are having both devices.
Yeah.
So I made you co-host for both the devices. Please try.
Okay, good evening, everybody. And first of all, thanks so much the organizers for having me here for this session on psychological impact of menarche, early menarche rather. So whenever we have a child who is giving history, I'll just start the presentation. Slideshow.
Yeah, it's visible, ma'am.
Yeah, okay. So thank you so much. So whenever we have a case of early puberty, early menarche, or even late menarche, we go ahead with a very clinical approach with correct clinical acumen and with the experts' opinion and reference. But many times what we miss is to include the psychological interventions, which should be part of the overall management of early menarche. So what are the consequences, or what is the impact of early menarche? So here we have a very typical case, which is 9-year-old girl who is obese and giving history suggestive of recent onset periods. So after history examination and all the discussion which we have heard before, the next thing we need to manage is the psychological interventions. So as we all know that adolescence is a period of development in various parameters which are actually complementing each other and coordinated with each other. In spite of all these, we find many adolescents that this period is very challenging and they need help in many problems. And here we have a child whose emotional, psychological, and social skills are actually not matching with the hormonal surge which the child is experiencing. So it is going to be a lot of problem for the parents as well as for the child. Similarly, at this early age, as madam has suggested, given us some insight about the use of pads and all that. So handling of periods will definitely need extra training. It will need more attention from the parents and will need more support. Means actually parent will have to use their, they will have to change the pads. They may have to change, wash the nappy and all those things. So that also should be included in the counseling part. So mother is actually ready and little more willing to be supported. Then there are other changes like body changes, secondary sexual characters, deposition of fat, vaginal discharge in between the periods, maybe typical body odor. So all these things are going to be disturbing for the child. And here we need a proper dialogue between the pediatrician or the endocrinologist or the gynecologist with the mother first. So maybe mother training is done before she is made aware of the challenges, and then she can pass it on that support to the child. But many times parents are so anxious because of these visits to doctors and all those things that they forget this psychological support which they need to give the child who is experiencing a very different problem in her life. Along with this, there are of course school absenteeism and certain school emergencies where child may not be able to handle the periods or heavy periods in the school time. So sometimes we have to sensitize the school also, or the teacher, especially the class teacher, so that she can be given help in the school as well. So a bit of preparing of mother is very important, and then she can offer support to the child. Now, what are the parental concerns apart from the pediatric or medical problems? What the parents need to handle here are, or they must know the fact that mental health issues are very common in children with early menarche. And as I've already told you, the reason is the imbalance between the different parameters of development during the adolescence. Eating disorder, as we can see, there can be cause as well as the effect of this thing, and they are very common. And many times food is used as a stress buster, and because they are already having anxiety and depression and other behavioral issues, so many times food is used as a stress buster, and which can add to the problem also. We see a lot of disruptive behavioral pattern because of the adjustment issues with the peers, with the school, and overall with the body changes and monthly periods. So child can be cranky, child can be irritable, child can be demanding, and again we need to train the parents for the same. There could be psychological, psychosocial problems depending on her interaction with the schoolmate peers. Suddenly child feels that I am the older one, I am more mature one, and the other kids are, they are talking like a baby, and I'm, little grown up, and so she may not exactly fit in the peer group, and that can lead to psychosocial problems. And the most dangerous of all this is the tendency of early sexual behavior. Because of the hormonal impact of hormones, there can be attraction, there can be sexual feelings, and that can lead to early sexual behavior. Even as we know that this is the period when children explore each other just out of curiosity, and these also can lead to sexual behavior. Then teasing, bullying because of the body changes, feeling of isolation, and of course the fear of sexual abuse. These are the children who are innocent. They may not know the consequences of their action or even the consequences of the other person's actions, and that can lead to sexual abuse. So these are the parental concerns a parent must be concerned about, and they may not be aware of this. So as a pediatrician or as a consulting doctor, we need to make the parent aware of these issues which they need to handle. At the same time, there are certain long-term impacts of early puberty or early menarche. Uh, Many times final height is affected. So child may appear a taller child when she is 9 year, 10-year-old, but ultimate height, she may not get what is expected of the otherwise. Then obesity, PCOD, and NCD are the risk factor because of early puberty. Then increased risk of reproductive and breast cancer. Maybe here we can give the hint to the mother that she needs repeated screening after the age of 25 for reproductive and especially breast cancer. Then HPV infection, and as madam has suggested, that teen pregnancy is definitely a risk factor. And as I visit one orphanage, I have seen multiple I would say children or adolescent who are 13 years, 12 years, and they are pregnant. So teen pregnancy is very common, though we may not have the exact statistics. and mental health issues, as I have already said, that they needs to be handled. Apart from the early menarche, the other issue is definitely late menarche, where a typical case would be a 15-year tall, lanky girl with no history suggestive of having periods. And as discussed before, after evaluation and treatment, there are certain psychological issues which needs to be handled. So the parental concerns here are definitely severe anxiety. Getting periods early maybe and gives anxiety definitely to parents, but not getting periods even at the age of 15 is definitely worrisome, and parents are going through a very severe type of anxiety, because they have to face the child, they have to face the society, the grandparents, the relatives, the friends, everybody. So it's a matter of great anxiety. Another thing which is important is that here, now not the child but the adolescent which we are talking, she is very well aware of the problem, because she's interacting with the friend. She knows that the talks are going on, someone is having periods, someone is having dysmenorrhea, they're exchanging pads, they're exchanging some information, there is talk about it, and the child, she is adolescent, is not having either secondary sexual characters and not the menarche. So here the adolescent is also equally anxious, and when it is age to fit in the peers, typical adolescent would like to be part of the social group. Here she will feel left out, isolated, and definitely will result in negative self-image. It will affect the interpersonal relationship and leading to stress, and these are the girls with very low self-esteem. This itself can lead to several mental issues. So even the delayed menarche can be a problem at psychological level for parents as well as for the adolescent. So in these both cases, the role of parent is to definitely first manage their own anxiety, because both these situations are very sensitive, and especially the mother would be very much anxious, and she is the person who is going to offer the support to the child. So they have to manage their own anxiety, and they have to take help or share their concerns freely with the consulting doctor. Then as far as their communication with the child is concerned, they have to be honest, they have to be positive, brief, and factual, and they need not show lot of emotional attachment or emotional angle to their discussion with the child, and their communication or their solving the queries or questions of the child should be in tune with the cognitive level of the child, and they have to break the information in a manageable chunks which the child can accept, digest, and uh, can move ahead with that piece of information. So role of parents in both the cases become extremely important. And they have to respond to emotional content of the question. Every time the question need not be answered in a very scientific manner, but they should understand why the child is asking. It is because of the anxiety, it is because of the feeling of insecurity, it is because of the feeling of being left out in the group. So that also they need to handle. And there are certain things they should be ready, because of the early sexual maturity. There could be queries related with the sexual questions, and nowadays they Google it, they talk with each other, they have information at their fingertips, they have mobile. So unnecessary curiosity about the LGBT, even in the delayed puberty especially, these are the questions which the parent need to be ready to answer in whichever way the child is asking, or they have to consult their pediatrician for the queries also. So they have to seek counseling to handle mental health issues, and as well as they have to sensitize the teachers and social contacts, because even if it is early or late puberty, everyone around the child would be asking questions regarding the physical presentation or the starting of period. So both these things are sensitive, and so we have to sensitize the surrounding contacts also. And a word about menarche in special need girls. Many times in special need girls, maybe autism, maybe mentally challenged or intellectual disability. Many times parents are so worried about their mental development and their therapies and other things that they just don't anticipate that, in a period of time, this child, special need child, girl child, is going to get periods. So here we have to train the parents to tell them that it is going to happen some or the other way. You can anticipate as and when the thilarchy is seen, and they have to be ready. Here we have to start hands-on training before the expected time. This is the message we must convey to the parents, because here, even daily activities are challenge for these special needs. So they have to use these hands-on training, how to use the pads, sanitary napkins. Especially in autism, they are very sensitive to touch, so they may not accept these additional sanitary pads in their panties. So that also we have to train them before the expected time, so that child and parent both are ready. The mother and the special educator needs to use lot of pictures, models, stories to prepare beforehand. Otherwise, they may create a lot of anxiety suddenly seeing blood and all those things. So pictures and stories can be used. And we have to focus on self-help skill. Many times parents focus only on academic skills or only on communication skill, but as you anticipate that the child is going to get the periods, the basic focus should be on self-help skills. Similarly, as in normal child, we have to teach self and safe touch, unsafe touch, and abuse. And these are the children who may not be able to communicate about their dysmenorrhea or premenstrual stress. So that also parent need to understand, depending upon the behavior of the child, that if the child is having dysmenorrhea, discomfort, or premenstrual stress or symptoms, and that also we have to train the mother to handle this. So take home message is that early, late puberty or puberty in special children, these are very sensitive issues. Parents as well as need support along with the child, and they need to be trained, empowered to handle these issues in the child as well. Management must include the counseling and mental health awareness, and regular follow-up is essential. Special need girls and their parents need early sensitization and training. So thank you so much for giving me this opportunity. Thank you.
Yeah, thank you, Dr. Jaya Shivalkar, ma'am. You have excellently presented all the aspects which are needed about the psychological problems during the early puberty, especially for the proper communication between the parent as well as the child, and early sensitization of the parents to their specially aided children. So over to you, Dr. Sudha Rao, ma'am, for your expert opinion.
Yeah, I think I will not put my video on because it goes a bit unstable that way.
Sure, ma'am.
Sorry about that. So this psychological aspect, I guess the academy should be appreciated for putting these things together in the perspective, not only the endocrine issue, the psychological and the gynecological. I think the think tank is wonderful to have this thing, this set of topics to be spoken to today. As far as psychological aspects of onset of menarche is concerned, I'll just narrate a story from my own patient base. This is a child who was 17-year-old and had gone through initial stages of puberty, had good breast development and some amount of pubic hair, and had come for primary amenorrhea. She had presented to actually for primary amenorrhea, and when her investigations were done, it was just some stress factor, which was, there was no hormonal imbalance which was found. She was a normal XX kid. There was no DSD underlying. There was no hormonal issue, no significant anemia. She was not really thin, but she was a normal BMI kind of a child. So to kickstart, it could be the other spectrum of the pubertal progression. So just to kickstart, some amount of estrogen was prescribed, some multivitamins were prescribed, and then she was asked to follow up in 3 months' time. Nothing was happening. Nothing was happening at all. I did wonder as to why this child is not going into a spontaneous menarche. There was the uterine ultrasound, uterus, everything, endometrial thickness, proliferation, everything was there. But what was realized in this whole thing is whatever intervention which was being asked to do, the child was not actually adhering to, because she did not want to have a periods. She did not want, she wanted to postpone it as far as possible. And that was a kind of a block there to get the child to realize that this is a normal progression to be meaning progressive, reproductively active or whatever woman. So these are the issues where we really don't know today. Children, they have so much access to the social media and other sources of information. They have their own decisions made even before we tell them what needs to be done. So, psychological aspect, as with all aspects of development and growth, I think even in this aspect, in this part of the maturation, it does form a very important role. And teaching them right from school time as to what is menarche, what is puberty, what is sexual development, that introduction should be there right from, I guess, mid school and beyond, where they would be able to know what to expect as children, because they are getting it earlier in terms of menses these days. And the other extreme is also there. Children want to have the periods, like you have an extreme age group where they are worried that they're not menstruating, whereas her schoolmates are all doing it. So that is another kind of a pressure, peer pressure kind of a thing which they face. So it's a very complicated issue, maybe difficult to pin down as to how to approach that, but educating them is, I guess, one important aspect. Yeah. Yeah. Any other comments? Maybe Dr. Suchita, Dr. Tushar.
Should we take the question answer so that the discussion will go further?
Yeah.
It was
Yes, I think
excellent presentation by all our experts. Dr. Suchita Madam, Jaya Madam, Tushar Sir and Sudha Rao Ma'am's comments were giving much insight into this complicated topic. Now there are some questions in the chat box. I'll cover that first. I think first question, this will go to Sucheta Madam. Sanitary napkin with a plastic layer, are they biodegradable and should they be used?
Not really. Ideally, they are incinerated, but unfortunately, there is no disposal system that we have. We don't even think for the people who actually are, segregating waste and all that stuff. So, ideal sanitary napkins, there should be incineration. Incineration should happen at local levels. This is what should happen, but nothing is happening. Nevertheless, between dry and waste, it's better that you dispose them in a wet waste, and it should be wrapped, the sanitary pad should be wrapped in a newspaper, that grade paper which is degradable easily.
Okay. I think second question is also for you. Is there a role of vitamin D levels in PCOS?
Nowadays, vitamin D is playing role everywhere, from our kitchen to toilet to bathroom to everywhere. So there are sessions saying that there is a role, there are studies saying there is no role. So I don't have a definite answer. It's better to have ideal level of all vitamins with all of us.
One more question is, can menstrual cup be suggested to adolescent girl? I think you have answered it in the presentation.
The best age, or maybe ideal age to use menstrual cup is after 17-18 years, when they get some maturity, and they are used to their cycles, they are used to their own body. But very young girl, 13-14, it's not worth suggesting a menstrual cup. But having said that, if the thing comes from girl's side that she wants to use the cup, she is motivated, she is ready to learn, there is no point in saying no. It can be used. I mean, there is no hard and fast rule.
Right. There is one more question related to this. Cotton pads means cotton clothes stitched together. How many months can they be used?
Either they are stitched together or they are just folded together. So of adequate thickness, which a girl needs to evaluate what thickness of pad she can hold and how long it can hold her flow. So it is out of self-experimentation. There is no hard and fast rule. If it's used regularly, it can last for months together, provided they are washed and dried properly. After few usage, if the cloth turns to be very hard, like a starched cloth, then it's better that they discard it and start using a fresh pad.
Right. Next question is for Jayashri madam. How to ask history of child sexual abuse and sexually active child?
Yeah. See, the method would slightly differ if we are considering it in a young child of, say, up to 10 to 12 years. And it would be slightly different if the child is in pre-adolescent or adolescent age group. So for children, many times we use pictures, we use stories to initiate the dialogue, and maybe we can give them the picture of swimming costume. Usually we ask them that, if it is a boy, it is a half pant, and if it is a girl, it is a bikini type costume is there. So from that picture, we can initiate the conversation. Do you like swimming? So likewise, and a child, if she has experienced this, then usually they share with us. If it is an older child, maybe we can have some direct conversation with the child, and depending upon the cognitive level of the child, we can start the conversation. But point is, we should not start it immediately when you are meeting the child or adolescent.
Right.
First, you have to develop the rapport. Then you have to ensure the confidentiality. Even you have to tell that even this will not be disclosed to your parents also. And then once the child is relaxed or the adolescent is relaxed, then probably they start sharing, because there is really need for them to talk. So once they find that the other person is willing to listen, then they start talking.
Correct.
So for younger children, we have to use stories and pictures.
Yes, that's true. Tushar sir, one more question for you. I recently met a girl who is 22 years, referred to me by a gynecologist, saying that the girl is having primary amenorrhea. Now, is it a pediatric endocrinologist case or adult endocrinologist case?
Yes.
Yeah, I mean, whoever is trained in looking after girls with, I suppose this is not just amenorrhea, this is hypogonadism. Had it been just, amenorrhea, then better a gynecologist takes a look at her. But then if it is associated with, delayed secondary sexual characters as well, then probably it's worth evaluating by a endocrinologist. Since the problem has started off from a pediatric age group, I would be happy if the pediatric endo has a look first.
Right, that's what I
said. Why should you compartmentalize things like that?
Yeah.
I think gynecologist knows basic endocrine, endocrinologist knows basic pediatrics. So, the point of start should be where the patient approaches first, and then you can take help of all colleagues.
Yeah, the unfortunate story is the patient until 22nd birthday has visited neither of us.
Yes.
That's the sad story.
Right.
She should have at least.
Patient would be more comfortable with the pediatrician. Because they are going to pediatricians, no? So
no, maybe not, because in our OPD the kids are very small, and at 22 year coming to that OPD, they may feel very awkward. So that's also an issue.
Dr. Rao madam wants to add something right now.
No, I just said there is something called an adolescent endocrinology. So it's neither an adult or a pediatric. So adolescent endocrinology is the story with everything which happens with adolescents. They are in the transition phase. You need to forward the care to the adult specialist. So if this 22-year-old is coming first, I'm sure they would go to the adult person first. Meaning from the way the system works.
Sucheta madam, one more question. I had one girl who had her menarche at 12 years of age. Then 3-4 cycles it went on normally for almost 6 months. Then there was long amenorrhea. She had her exams, and that went on for around 4 months. Then she got the periods. Then she again went into exams, again amenorrhea. So every time, 2 times I did this reassurance and some multivitamin and just placebo effect के लिए treatment दे दिया. So when we should refer this thinking as significant time of amenorrhea or irregularity.
See, if she had her regular cycle for 6 months, you said, and then followed by a period of amenorrhea, secondary amenorrhea, and there was an obvious stressor that her exam and all her, physiology and circadian rhythm, everything changing because of that. This is quite common and natural. So I think she needs to have a strategy to cope up with stress. That is number one. Now, this is the age again. Every time you need not blame it to, exam. 10th exam zali, 12th exam, and then every time exam and amenorrhea may not be true. There can be certain other things for secondary amenorrhea. So usually if secondary amenorrhea getting repeated again and again, I think it's worth doing at least basic thyroid and prolactin levels. If they are normal, then it's okay. She can be given withdrawal bleeding. Of course, don't miss the opportunity to tell them, inquire them about their being sexually active. If so, then usage of contraceptives. Because many a times teenagers are not that naive as they appear.
Yes.
And they are quite active.
Right.
And if you ask them a direct question, I mean, in my OPD, earlier I used to feel awkward asking them whether to ask in front of mother or no. And nowadays, I mean, after the at current era, I straight away ask them, are you sexually active? And then they'll say yes or no. I mean, they will not feel offended.
Right.
So at least it's better to ask them. And then afterwards you can say, so for a doctor, from my side, I need to ask this question to everyone, and hence I ask.
Correct.
If not, fine, then let's move ahead.
Yes. There seems to be one more question. Does early menarche any association with early menopause?
No.
Dr. Tushar sir or Suchita madam, anybody?
No.
And if yes, then what will be the earliest stage for menopause?
There is no association between earlier menarche and earlier menopause. Both are different things.
Right.
Am I correct, Dr. Tushar?
Yeah, I agree. Although conceptually, if a female has finite number of eggs, so maybe a year earlier, but then whatever papers they are present, there is no definite association. So we don't know basically.
Jaya madam, there is one more question asked many times by the parents. At what age we should start giving sex education per se to the child? What should be the age of the child? When should we start?
Yeah, nowadays, of course, we won't label it directly as a sex education, but considering the type of cases which we are seeing, I think as early as 3 years, 4 years, we have to start at least safe and unsafe touch, and then the concept of some body parts.
Right.
And then as their cognitive maturity is occurring, we have to give them some factual information related with the body parts. And then gradually, along with their academic lessons, we can definitely do that. But as well as depending upon their sexual maturity, time of puberty. If it is early, then of course we cannot rely only on age, but we have to depending upon the sexual maturity, we will have to expose the child to this information also. So as early as possible, and in a language they understand, would be the correct approach. And with the exposure of Google, pornography, that is one area which I have not touched, but these girls are very much into these type of activities. So basically nowadays we have to start as early, and communication with the mother, I think, would be the best thing.
Right. Mohite sir, are you there? Has he left the meeting?
Sucheta ma'am, in case of special needs children, do you have any in your lifetime any this thing that they want to get operated for hysterectomy, like in Down's children or like that?
Yes, in Downs or other mentally retarded or challenged girls, or those girls who are unable to take care of themselves. At times, parents take care of their hygiene and these things, but at one point of time, they do come with the request of operating and doing a hysterectomy.
Yeah.
So,
I had one
each
girl.
gynecologist comes across, I think, such incidents, and here we need, special certificate and a medical record to say that this particular child is mentally subnormal or challenged and cannot take care of herself, and then she can be very well operated.
Yeah.
There
Thank you
was
so
one
much.
lady who was mentally challenged, and she was HIV positive, and she got pregnant. She delivered, and again she just ran away from the institute, and again after some days she came with another pregnancy. In the meantime, she must have passed HIV to so many people. So I think sometimes hysterectomy would be the correct approach.
But that will not prevent passage of it,
No, that
transmission
will
of
not
HIV.
prevent. Yes, that will prevent only
Unfortunate incidents.
Yeah.
The questions in the chat box are over. Renu ma'am, you can.
Yeah, almost they are all over. And I think Dr. Sudha Raman, do you need to sum up and the comments, because in the start you were not able, we were not be able to hear you. Yeah, ma'am, Dr. Sudha, ma'am. Okay. I think madam's audio is not heard. So over to you, Dr. Amol Pawar, sir. He is the Secretary General of MahaIP. He will deliver the vote of thanks.
Thank you, Renu. Good evening, everyone. I thank respected Dr. Sudha Rao ma'am, who in spite of her busy schedule agreed to chair the session as mentor, and there was great learning experience from her. And what to say about Tushar, a seasoned player on national platform in the field of endocrinology, one of the gem of our Nashik IIP. Thank you, Tushar, for the hard work done for your PPT and to explain Menarche in very simpler way through various flowcharts. I also thank Mrs. Lady President-elect Dr. Sucheta Kinzwadekar ma'am for enlightening us on various aspects of Menarche from gynecological point of view. Then our third speaker, Dr. Jayasri Sivalkar ma'am, one of the leading faculty on MahaIP platform nowadays. Thank you, Jaya ma'am, for nicely covering various psychological aspects around Menarche, including girls with special needs, in most simplest way you can. Also, I thank Dr. Chetan Shah sir, Vice President, West Zone, for giving your blessing at the start of the program. And also he was there most of the session. I thank today's moderators, Nilima Bhandarkar ma'am and Renu Moralkar ma'am, who is the chairperson of MahaIP Women's Committee, for conducting today's session and also coordinating amongst speakers, that is mentees and mentor in last 2 weeks. Lastly, I thank all the colleagues who have joined the session through Zoom and YouTube. I request you all to attend our next MahaIP activity on thalassemia along with Amravati IIP team. This is a 3-hour CME with panel discussion on International Thalassemia Day, that is 8th May, Sunday. Thank you one and all. Thank you.
Thank you all.
Yes, good night. Good night.
Good night.
Thank you, Suchita ma'am.